And you are welcome to share if you've got a presentation, but I hand over to you. Thank you very much.
Thank you for the warm welcome, Jackie. As you can see, I've been all over, but still South Africa is at my heart, and I don't think I'd leave South Africa. Let me start sharing my screen. There we go. I think you can see my presentation.
I can, it's just not in presentation mode.
Yep, oh, there we go. Is that fine? Everything okay?
Perfect, Doc.
Okay, thank you. So it's really nice talking to pharmacists, especially since I did my master's in pharmacokinetics. The reason why I did that was because I was getting involved in clinical trials, and I needed to understand how medications work. And it's not as simple as you think, you know, just prescribe something and don't really worry about the side effects. There's a lot of things that need to that you need to keep in mind. And that's where we come to the essentials in the modern management of diabetes. Why? Because a lot of medication has changed in the recent years. And what has happened, the focus then has been on lowering blood glucose. And I'll take you through this as the slides progress. And then we've now confronted with a big problem of hypoglycemia in type 2 diabetics. So talking drug and talking a little bit about the clinical background of diabetes is going to perhaps help you in managing the patient that comes to you, that comes to collect their scripts for insulins and oral anti-diabetic agents. So moving along, the views expressed in this talk are my own. So this is just the disclaimer slide. And I have given talks for other pharmaceutical companies as well in the interest of promoting diabetes education. So when you're looking at diabetes, and perhaps because maybe I'm talking now to pharmacists, I'm not sure if you're aware of this clinical trial that took place. This was a clinical trial called the UKPDS, right? The UKPDS study was done in type 2 diabetics somewhere in the 1980s. And what they did then was they took patients who then had conventional control. The conventional control then was keeping blood glucose values above 15 to prevent patients from getting hypoglycemia. Then they took patients and put them in an intensive control section where they tried to keep the blood glucose values between 4 and 10 and HbA1cs under 7%. Now, this is where the clinical aspect comes into play, and perhaps you won't be privy to that kind of information when you're confronted with the patient. But it is because of this that we've changed our management practice in diabetes. And from the study, what we clearly found is that even a 1% reduction in HbA1c reduced deaths from diabetes by up to 21%. It reduced heart attacks by about 14%. It had a big impact on microvascular complications of a decrease in 37%, and a massive impact in peripheral vascular disorders with a decrease in 43%. So this was very exciting for diabetologists and those looking after diabetic patients, because even if the patient had an HbA1c of 10 and you brought it down to a 9, we got very good results. And this is the point of diabetes. The point of diabetes is to prevent complications. So we knew that if we brought the glucose values down, we're getting a beneficial effect in terms of prevention of complications of diabetes. There were further studies done looking at where the HbA1c should be in order to prevent these microvascular and macrovascular events. And what they found is that in the light blue bar, across each of these parameters that they were looking at, microvascular events, macrovascular events, and death, they found that there was a significant difference in patients' complication rates if we aimed for HbA1cs between 6.5 to 7%. So that was the aim then for most diabetics, and this is our target. And that's why doctors are meant to progress therapy in order to achieve these kind of this type of glycemic control in the patients. But then the doctor said, so how low can we go? If 6.5 is fine and you're getting about 20% reduction, just a 20% incidence of microvascular and macrovascular complications, can we go even lower? And what we found is, this is a summary slide in which different studies were done. So the UKPDS I mentioned earlier, that was done in the 1980s in type 2 diabetic patients. And then just below this, we have the DCCT study, which was done in type 1 diabetics, also looking at what can we do with good control. And at that time, it was aiming for an HbA1c of 7%. Later on, somewhere in the 1990s, we had the Accord and Advance study. And what's very important here is all of the Accord and the Advance and the VADT studies that were done later, where we tried to aim for as low as you can go HbA1c. And what we found is in certain studies, like specifically looking at the Accord study, there was a reduction in microvascular events. There was not a big impact on cardiovascular disease, as was common through all the studies that were done in terms of diabetes control. However, in the Accord study, you can clearly see there was an increased risk of mortality. And why that occurred is because they found that patients had many hypoglycemic events. And it is because of these hypoglycemic events, the study had to be stopped early because patients died from cardiac arrest secondary to hypoglycemia. So we discovered, hey, we better be careful here. We can't drop the HbA1cs to as low as we'd like to go. And what is also clear from the studies that were done is that good diabetes control gave us better microvascular complication prevention, but not too much of a benefit in prevention of cardiovascular disease. And that's where the newer therapies in diabetes now, which you guys are probably inundated with on a day-to-day basis, because patients want to use these drugs for weight loss, right? So we're talking specifically now the GLP-1 receptor agonists. And they're so brilliant because initially the GLP-1 receptor agonists showed an improvement in HbA1c, but it showed a marked improvement in cardiovascular disease. With the studies that were done, there is the once weekly preparations we have available, and you're probably getting phone calls every day now. The drug is out of stock, etc., for various reasons, mostly because of demand. And what we're finding is that the semaglutide, the once weekly semaglutide, is used for secondary prevention of cardiovascular disease, and it had a great impact in lowering weight and specifically macrovascular complications. And then the dulaglutide, which is the Trulicity, gave you primary prevention of cardiovascular disease. Both drugs gave weight loss, but the one gave more weight loss than the other. And that's the reason why we're having a problem getting these drugs on hand, because even non-diabetic patients now want to use the drug because of its effectivity in weight loss. So weight loss is a big market, as you know, and that's the reason for that. In terms of HbA1c targets, the SEMSA guidelines 2017, which was when it was last updated, it's going to be updated sometime soon, and we should get our new guidelines out soon, state that we need to aim for an HbA1c of under 6.5% for newly diagnosed diabetics and under 7% for majority of patients. In patients who have multiple comorbidities and a limited life expectancy, we need to aim between 7.1 and 8.5%. And the reason for this is specifically because of the risk of hypoglycemia in elderly patients with multiple comorbidities. And this was hypoglycemia becomes one of the major causes of death then in patients who take the medications incorrectly, or the doctor has the wrong choice in medication because he just heard a talk where you need to focus on a lower HbA1c, and he's very enthusiastic and it starts the therapy, and lo and behold, the patients get hypoglycemia because they now may be very compliant to therapy, or they decided to have a better diet and start exercising, and suddenly you get hypoglycemic events. So although UKPDS, all these studies have stated that HbA1c below 7% is very beneficial in preventing complications, we find that most type 2 diabetics don't achieve this HbA1c under 7%. And this problem is not only prevalent in third world countries, where they consider us third world, but it's also prevalent in first world countries. I mean, if you're looking at a country like the UK, only 39% of patients are achieving that HbA1c under 7%. Netherlands is doing quite well, but if you look at other countries like Germany, France, Belgium, they're not really doing well. Italy, only achieving 36% of patients are only achieving those kind of HbA1cs. Perhaps this is because they have the good pasta, I'm not sure. But yeah, so worldwide, this seems to be a problem. And South Africa is we don't have the data here, but South Africa is somewhat in the region of between 40 and 50% of patients achieving HbA1c under 7%. So although we know that complication rates can be decreased with good control, we're not getting there. Even in first world countries, they're just really not getting there. So we still have this burden of microvascular as well as macrovascular complications because we're not getting there. Now, one of the reasons for this is treatment inertia. Doctors are not checking HbA1cs, and they are not enhancing the treatment or treating the patients to target of HbA1c below 7%. The second most important reason is compliance. And this is where I think you have the upper hand, because you know if a patient's fill their script and if they're filling their script on time. There was a time where we were part of the Center for Diabetes and Endocrinology, and we used to dispense medication to the patient. And the patient came in and we said, okay, fine, these are your insulin doses. So you need 4 pens per month. Okay, we're going to dispense 4 pens to you. And sometimes the patient says, no, doctor, I don't need it. I've got about 6 pens at home. And I'm like, no, you can't be having 6 pens at home. Because if you're taking the insulin correctly and you're taking it daily, you should be finished with the number of pens that have been dispensed to you at the end of each month. I know you don't have the time to speak to every patient and ask them how many pens they have left and why they're not collecting insulin, or are they just collecting it? And one patient said to me, doc, I've got so many insulins and metformin boxes at home. I can actually open up a spaza shop and sell these drugs to the people in the area. And I was like, this shouldn't be the case, but it is. And I suppose you guys can see firsthand how often patients fill their scripts in and whether they're taking their treatment correctly and are compliant to therapy. So 2/3 of patients with type 2 diabetes do not reach the HbA1c target, right? And when we start patients on basal insulin, we find that within the first year of having started insulin is when the patient is at their greatest risk of hypoglycemia. Because this is the stage where you're telling the patient, hey, your HbA1c is above 9%, we need to start basal insulin. We start the patient on this because it's a new drug. They're a little bit afraid. They now suddenly deciding to have a better diet because patients don't like insulin, and they get a little bit afraid when you're starting the injectables. And you find this is where the patients are at the highest risk of experiencing hypoglycemia. So if you get a patient that's coming to collect their basal insulin and you know this is different from their usual therapy, please make a point of asking that patient, are you experiencing hypoglycemia? Do you feel hungry at night? Because if you do, please go back to your doctor and speak to your doctor, because hypoglycemia can be a big problem in terms of mortality, right? So there are different types of hypoglycemia. So if the patient says they're feeling hungry all the time, it may not be a true hypoglycemic event. We have different types of hypoglycemia, or we defined hypoglycemia according to these two definitions. The one is symptomatic hypoglycemia. So if the patient has had higher glucose values and they're running at 15, 16 millimoles per liter all the time, and the doctor suddenly brings the glucose values down because we've adjusted therapy or started them on insulin, you find that the patient can experience hypoglycemia even at a value of 10 millimoles per liter on a finger prick test, okay? And this we call symptomatic hypoglycemia, because there's a deficit of approximately 5 to 6 millimoles per liter very quickly. And the patient can then experience hypoglycemia when their blood glucose values are not in the true hypoglycemic zone. So what we recommend patients to do is to test their blood glucose, and they need to test it regularly. They can't tell you, doc, I can feel hypoglycemia. I can feel when my sugars are high, because we actually did a kind of an experiment with patients, because we have patient days now and again, especially around November, which is diabetes month and diabetes awareness month. And we said, okay, let's see, we had a function for the patients, and we tested all their blood sugars, and we said, look, I want you to guess your glucose value, and we wrote it down, and then we got a nurse to test the patient's blood sugar, and we wrote down the true value. There was only one patient in 100 patients that we had there that actually could guess what their glucose value was, depending on how they felt. So you cannot guess. You don't know what your body is feeling. You need to test the value to be sure that you're truly having a hypoglycemic event. If your blood glucose value is above 4 millimoles per liter, then you can go ahead and have that, whatever you wanted to have, to take the blood glucose values up. Because diabetic patients actually kind of prefer the hypoglycemic episodes, so that they have a license to eat chocolates and whatever, Cokes and whatever that's around. Understandably, diabetes is a lifestyle change, so you have to eat better and change everything that you do, and not many people embrace it. So although we do get hypoglycemia in patients when they start insulin, most patients don't even achieve that, as you saw in the previous slides. So hypoglycemia then can be mild, moderate, or severe. Mild is where the patient feels a little bit shaky, a little bit hungry. They're able to go to the kitchen or take out their lunchbox at work and have something to eat. Then you get severe hypoglycemia, and that is where the patient collapses and cannot assist themselves. So they will need somebody else to either administer glucagon or give them some sort of glucose-rich fluid to drink or something like that for them to feel better. So this is how we define hypoglycemia. So we need to be sure that the patient has a true hypoglycemia before we start adjusting doses or stopping insulin or telling them, oh, I don't think you're diabetic. They need to check. And then what causes hypoglycemia? Most often, it is a delay in meals, or decreased food intake when they're fasting. So a lot of people now are doing the intermittent fasting, and they're doing like the Banting diets where they're not having carbohydrates, and this does result in hypoglycemia, right? Patients exercise. I see more and more patients, actually younger patients, who continue to exercise, and they do high intensity interval training, which takes a lot of energy, and they don't tend to check their blood glucose values before they start exercising. So sometimes they're going straight after work, go and exercise, and then they'll have supper once they get home. However, if the glucose value is already low prior to the exercise, they can end up with a hypoglycemic episode, which could be dangerous. The only two medications that cause hypoglycemia is insulin and sulfonylureas. Okay, so these two are the only two. So insulin obviously supplements endogenous insulin. So if endogenous insulin is not being secreted, we give exogenous insulin in the form of an insulin injection. And if you don't time the dosing correctly, or if you take insulin and you don't eat, you can end up with hypoglycemic episode. So too with sulfonylureas. So specifically with regards to insulin and sulfonylureas, when it comes to dispensing medication, make sure that the patient knows how to take the insulin. For example, if you're using a pre-mixed insulin, depending on the type of pre-mixed insulin you have, you may have to take it 10 to 15 minutes before meals. And I say before meals, not after meals. So make sure the patient understands this. And if you're taking sulfonylureas, they need to be before meals, not after meals. And definitely not after supper, because then you could get hypoglycemia because of the medication that the patient's taking. So they need to know how the treatment works and exactly when to inject and when to eat, right? Post-injecting. Otherwise, other things do happen. I mean, you may be diabetic, but you could get a gastrointestinal bug, and then you've got vomiting and diarrhea. Of course, you're not taking anything in. You may have injected in the morning, and this diarrhea, vomiting starts happening around, say, around 12 in the afternoon, if you're taking a premixed insulin, or you've taken your sulfonylurea in the morning, and now the drug is absorbed, but you can't eat. In which case we have to teach patients how to manage keeping their glucose values up in these situations. Patients who suddenly get hypoglycemic episodes have to, and not related to gastrointestinal issues, have to check for renal failure. So the doctor needs to do urea, creatinines, and GFRs, etc., to try to figure out if this patient has renal failure. Why is this happening? And then some of the rarer causes of hypoglycemia is when patients may develop an insulinoma, in which the body is producing too much of insulin, and then you get these conditions called idiopathic hyperinsulinemia, which is more prevalent in younger patients and neonates, right? So this is just for completion's sake. The important one here is timing of insulin injections and knowing that you cannot take insulin sulfonylureas and not eat. So that is very important. So in terms of the SENSA guidelines, the treatments that we have available for diabetes are as follows, right? So they're all listed alphabetically. They're not listed in order of preference. So if you're looking at monotherapy, we usually start with metformin, right? If patients have lots of gastric side effects, we prefer metformin XR because it has a pharmacokinetic profile that is very, very steady, and it covers you over 24 hours. If you're using the regular metformin, in some patients, you get a peak and you get a decline, and then you need to time the tablet correctly to get proper cover. So the drug has a 12-hour action. So preferably, we need to use the metformin BD if you're not using the XR or the extended release formulation. If patients cannot tolerate metformin, despite using XR formulations or taking the drug post-meal, metformin you can take post-meal to reduce gastric side effects. We then use DPP-4 inhibitors. Because DPP-4 inhibitors do not cause hypoglycemia and they don't have gastric side effects like metformin. Post that, you can either, so if the patient can't tolerate that either for some reason or because of funding and costing issues and medical aid sort of problems, the best next option then is gliclazide MR. If you look at this list, you can see that in terms of sulfonylureas, and it's in the South African guidelines, endocrine guidelines, it's in the NICE guidelines in the UK, it is in the ADA guidelines, it is in the European guidelines. It is the only drug that is mentioned by name in the guidelines. And there's a reason for that, because gliclazide MR has the lowest rate of hypoglycemia amongst all the sulfonylureas that are available. So if you have an option, rather choose gliclazide MR over any other sulfonylurea for safety reasons and for compliance reasons, because this is the only sulfonylurea that give you proper 24-hour cover with very little hypoglycemia. So this drug is mentioned by name. Thereafter, we have options like pioglitazone, which is a thiazolidinedione. It is the most potent insulin sensitizer that we have. However, contraindications are patients with heart failure because it can cause fluid retention, and the other side effect is weight gain. So patients can pick up about 5 to 10 kilos of weight by using pioglitazone. They say that the weight going up could either be fluid retention, and other than that, it does redistribution of fat from visceral fat to subcutaneous fat. So fat that may have been lying in your liver and lying around your heart will be redistributed to subcutaneous areas. And patients are not happy with that because they tend to look a little bigger. But it definitely has a fantastic benefit in terms of insulin sensitivity. It is the most potent insulin sensitizer that we have available for diabetic patients. Then we come to the GLP-1 receptor agonists. They are probably one of the safest drugs you can use. They don't cause hypoglycemia. They're as potent as insulin and sulfonylureas for HbA1c reduction. They give you cardiovascular disease prevention. They give you weight loss, and they give you good glucose control. So some primary prevention, some secondary prevention, like I mentioned earlier. The only side effect and the most common side effect is nausea and vomiting. So some people can't tolerate it at all. Other side effects, which we're still trying to work on, is progression of retinopathy in certain patients who have underlying retinopathy. So if the patient can't see and they're getting blurred vision, it may be the GLP-1 receptor agonist. Have your eyes, ask the patient to have the eyes checked out at an ophthalmologist to look out for retinopathy. And then we have insulin. So these are the drugs that we have available for diabetes. There are multiple DPP-4 inhibitors available. There is only one TZD in terms of pioglitazone. There are multiple GLP-1 receptor agonists, from twice daily to once daily, and now once weekly preparations, and multiple insulins, from basal insulins to premix to co-formulated insulins. So there's a lot out there, and we're getting a lot more because we're going to get combinations now of GLP-1 receptor agonist and GIP, which is glucose insulinopeptide, GIP, which is also an incretin hormone released together with GLP-1, that's going to give you weight loss to the effect of 25% of your body weight. So that is still to come at a price, of course, but at the moment we know the crisis that we're having with the GLP-1s. But these are the drugs that are available. The only two that really can cause hypoglycemia are insulins and sulfonylureas. And so what are the factors that contribute to this poor control in our diabetic patients? Number one, lack of dose titration. Patients start on treatment and they want to stay on it for life. Yes, they need to go back to the doctor for a script, but quite often, and I don't know how, they just get a repeat prescription without going back to the doctor for the doctor to evaluate their HbA1c. And if this is done 6 monthly HbA1cs, then you can prevent complications and you can address the issue should the glucose values go up, right? Otherwise, patients don't like to take treatment because they feel they're gaining weight because of therapy. But the number one reason why patients don't like to take their treatment is if they have one hypoglycemic episode, the trauma they experience instills a fear of hypoglycemia, which they carry with them for life. So they're very afraid then to use therapy, right? Hypoglycemia does compromise patients' compliance. It results in poorer adherence to diet recommendations because patients then go to bed, and before bed, they're having half a chocolate or having a small glass of Coca-Cola, not the sugar-free version, in order to make sure that they don't get a hypoglycemic event at night. It also leads to poor adherence to insulin therapy, and you can give that patient that altered dosage, but what you find is they decide on their own dose. And you guys see that all the time, I'm sure, right? So patients don't like to have tight glycemic control because of hypoglycemia. And 72% of physicians themselves agreed that they would not treat their patients very aggressively if there was a risk of hypoglycemia. So physicians themselves don't want to cause harm, which is obvious. But if you understand the drug and you understand the pharmacokinetics of the drug, you can do it safely. And of course, the patient needs to eat correctly. The patient needs to use the drug correctly, and the patient has to be testing their blood glucose values. So what happens with hypoglycemia? Basically, at a blood glucose value about 4 millimoles per liter, and the patient is the body is still producing insulin, you find insulin secretion is then suppressed. At this stage, the symptoms that patients experience is hunger. They feel very sweaty, and they can feel tired. People get various symptoms. Some of them lose focus and they get confused, and that happens usually at a value of about 4. When the glucose value drops to about 3.8 millimoles per liter, the body then starts releasing glucagon and epinephrine. Why glucagon? Glucagon promotes gluconeogenesis at the level of the liver, so the body can try and release glucose from the liver to prevent the patient from getting deeper into a hypoglycemic episode. And this is a protective mechanism by the body. At this stage, the patient starts shaking and experiences tremors. At a value of 3.7, there's a decline in blood glucose uptake, and this patient can either become irritable, violent, they can even experience some sort of seizures at this point in time. At a value of 3.5, the body starts releasing growth hormone and cortisol, and the patient feels very hot and they start sweating. And then at a value of 3.0, they can get all of the above symptoms, and the body now goes into glucose autoregulation. At a value of 2.7, the body then starts releasing neurotransmitters, and the patient can experience cognitive decline as well as cardiac arrhythmias. So it is at a value of 2.7 and below that we have a problem. However, if patients have very tight glucose control, sometimes even at a value of 3, they have 0 symptoms. And this is called hypoglycemic unawareness, which is a big problem. And it's usually more common in type 1 diabetics that really want their glucose, want to run their glucose values very low. So there are those that are very, what can I say, OCD about their diabetes. They hate blood glucose values that go above 6. And the problem is it's really good in terms of prevention of complications. However, when they run their glucose low, their body does not respond to hypoglycemia because they take that as a standard for their body. So they do not get the glucose counter-regulatory response, which is natural for protection, protection of death and going to a coma and cardiac arrest. And these counter-regulatory hormones like glucagon, adrenaline, cortisol, etc., do not kick in. And the patient then can result in a severe hypoglycemic episode, which could also result in mortality. Right? So what are the immediate managements of hypoglycemia? So the type of advice you can give the patient, should they come to you and say, look, I'm using this treatment, but I don't feel well. And what can I do if my sugars are low? They could drink a cup of milk. They could have sweets that are high in glucose, like Super Cs and fizzes. You do also have the glucose the glucose preparations at the pharmacy, which patients can use. They can take half a glass of fruit juice, especially grape juice. These takes the values up. But remember, this is only going to assist if the patient has mild hypoglycemia, right? Now, this is not for patients who are really severe, because they obviously will not even be drinking. They won't be able to ingest anything because they're out of it. They can take a package of the glucose gel, or you could give them sugar or honey. Right? For moderate to severe hypoglycemia, which is values that are under 2.8 millimoles per liter, where the patient needs assistance, the two options that we have available is what they can do at home is give themselves a glucagon injection. But this only works if the patient hasn't been doing a banting diet, because with the banting diet, you're depleting your glucose stores in the liver. And then what happens is, even if the patients take glucagon, there is no glucose to get gluconeogenesis. And therefore, these very strict banting diets, very low or no carbohydrate diets in diabetic patients gets very dangerous, especially those patients who are type 1 diabetic on insulin. In these patients, the only thing that's going to help is a dextrose infusion, in which case the patient can't do it themselves. You have to contact either the ambulance, take them to the hospital where they could get a drip and get some assistance. So glucagon injections work, but please try and ask beforehand, is this patient following some sort of a banting diet? Are they like in a starvation state? That sort of thing, because then you know the glucagon is not going to work. It will only work if the patient has glycogen stores in the liver. So let's look at the physiologic insulin profile. Usually, when patients eat breakfast, lunch, or dinner, they get a bolus of insulin that is secreted prior to breakfast, prior to lunch, prior to dinner. And then if they don't eat, you get a flat basal insulin curve, right? So how do we mitigate the risk now of hypoglycemia? We need to understand the pharmacokinetics of insulin and how we need to be giving this therapy. Patient needs to be educated. They need to be educated on what the correct diet is, especially in this day and age of bantings and etc., the low carb diets. We need to inform them that it may be dangerous for them. We need to educate them on sick day management. If a diabetic patient comes into the pharmacy, you know them, you know they're on insulin, and they say, oh, I need something for vomiting and diarrhea. Try and ask them a little bit more about what they're experiencing. And you can give them that advice about what to do. And then you can also dispense a glucagon pen, especially if the patient hasn't been following any of these strict diets. And the glucagon can then perhaps save a life where the ambulance takes too long to get to the patient. Patients need to be educated again on the use of their drugs. They need to know how to store it, how to use it in terms of timing before meals. Basal insulins need to be taken in the evening. Analog basal insulins can be taken at any time, but this is something we need to make sure the patient understands before they take the drug out of your pharmacy, especially if the doctor didn't do it. Or contact the doctor, send them a message and say, please, you need to educate this patient because something doesn't look right here. And patients need to be testing their glucose to prevent hypoglycemia. In terms of doctor factors, again, education. Choose safe drug options like the sulfonylureas, like gliclazide MR, which is mentioned by name in almost all guidelines. In terms of basal insulins, we have safer basal insulins, like the analog insulin degludec and the U300 glargine. Much less variability, a greater than 24-hour glucose insulin release, and the timing of the insulin is flexible. So you can inject those either in the morning and you have a 6-hour gap in which to inject them, and they've got a flatter profile. So in patients with hypoglycemia, you can recommend to them analog basal insulins and say to them, look, your medical aid may not pay for it, but in terms of your life, you may have to co-pay, but at least you get you protect yourself from getting hypoglycemia and the serious adverse events that can occur because of that. So in terms of hypoglycemia risk, and now specifically looking at the sulfonylureas, they looked at all the drugs, and like I mentioned, insulin and sulfonylureas are the two that cause the most hypoglycemic episodes, right? And if you're looking at this slide, you see the other drugs like metformin in the green on the top, in the orange color, the DPP4 inhibitors in the purple color. We've got the GLP-1 receptor agonists, and then we've got the SGLT2 inhibitors in the green. And you can see they're already very safe in terms of hypoglycemia. The only time the patient would have a higher risk of hypoglycemia with these drugs is if they're used in combination with a sulfonylurea or with an insulin, okay? So now looking in the blue section of all the sulfonylureas that we have available, the safest one, so the one that is closest to in this forest plot, closest to the blue line, is obviously the safest, right? So what's in favor of the drug in terms of what you're testing is that which is on the right-hand side, and what's on the left-hand side is not in favor of the drug. So here we're looking at hypoglycemia risk, and you can see that gliclazide MR is the safest sulfonylurea we have in terms of hypoglycemia. So if patients tell you that they have issues with that, this is what you should ask them to recommend to their doctor to prescribe in terms of safety. So despite the fact that gliclazide has the least hypoglycemic episode, it still is more potent than other sulfonylureas with regards to HbA1c reduction. So we're trying to get HbA1cs to 7%. We're trying to get it there in a cost-effective manner, because from all the drugs that are listed there, the GLP-1s and etc., although they don't cause hypoglycemia, and they have very potent HbA1c reductions, they're still very, very expensive. So gliclazide MR specifically has very potent HbA1c reductions without the hypoglycemic risk. So there's a clear interclass difference in terms of cardiovascular safety as well among all sulfonylureas. So again, with this forest plot, if you're looking at the drug that is closest to the line that doesn't cause hypoglycemia, it's a gliclazide highlighted in the light orange. So it does give you a beneficial effect in terms of lowering your risk of cardiovascular mortality. and probably associated with a much less hypoglycemic episodes and therefore less mortality. Right. So when you're adding basal insulin therapy, you do have a greater risk of developing hypoglycemia. So this is a glucose profile of a patient that was using CGMS. We started the patient on insulin, basal insulin. The entire curve came down. But what you find is that certain points where the glucose dipped, you find that that patient now is in the hypoglycemic zone because of the basal insulin that they used. So this is something that we need to be aware of. Not all patients are doing CGMS, which stands for continuous glucose monitoring. They're doing finger prick tests, and they may just be checking their sugars at random times, and we're not picking the hypoglycemic episode. And this does happen with the older basal insulins that we tend to use. So what are we looking for in the ideal basal insulin? We're looking for glycemic control that is effective, once daily administration with the flat time action profile. We're looking for those with the low risk of hypoglycemia with very little variability. And we're looking for the possibility of flexibility of dosing, because most of the time, if patients are using the older generation basal insulins, like the NPH insulins, the protaminated insulin, the patients need to be taking that insulin at 10 o'clock at night. And then what happens? They come home from work, they're really tired. They say, okay, I'm just going to have a little bit of a nap, and then I'll take my insulin a little later. And then what happens is they either don't get up to take it, or they take it early and they fall off to sleep and they don't eat. And then you can end up with the patient with poor control and hypoglycemia. So we need basal insulins to be soluble and have a neutral pH to avoid burning. At the injection site, the newer analog insulins can do that. We need it to be peakless, so you get less hypoglycemia and therefore less weight gain, because hypoglycemia is a license to eat chocolate and cokes and that sort of thing. The time action profile needs to be predictable and reproducible so that patients know what to expect every day. And this can avoid frequent variations in glycemic values. So the challenges that we have at the moment with basal therapy is that the older basal insulins have a very poor pharmacokinetic and pharmacodynamic profile. And there's a lot of intra-patient variability. There's a high risk of hypoglycemia with the older basal insulins. And if the patient experiences a hypoglycemia even once, they will have a fear of hypoglycemia, and they also don't want to gain weight. So that's the problem that we have with the basal insulins. So hypoglycemia does have a very big impact on patient care. It does higher their risk of treatment discontinuation. There is an increased risk of multiple hypoglycemic episodes in those patients who really want their glucose values to run at between 5 and 6. It does result in decreased work productivity, because if patients have a hypoglycemic episode, although they can correct it within 10 minutes, they have a hangover effect for up to 6 hours post that hypoglycemic episode. And that's literally the entire day, of work. So if you have colleagues in that who are diabetic, you just need to ask them. They will tell you how hypoglycemia impacts on their life. I think about a child that's in matric, a type 1 diabetic, and what that can do for the patient. So try to advise your patients on the safer options in terms of prevention of hypoglycemia. And long-term complications and even acute complications with hypoglycemia are many. So hypoglycemia can result in death in older type 2 diabetics, and this is usually within the first year after starting basal insulin. In terms of titration, adherence, and achieving glycemic targets, doctors are reluctant to titrate the doses simply because of this fear of hypoglycemia, as well as a reduced willingness in terms of the patient to follow the diet or to intensify therapy. So patients who have had a hypoglycemia tend to target a higher nighttime glucose value due to fear of nocturnal hypoglycemia. And therefore, they don't check their sugars then at night, and they try to hide this from you. So you need to understand how the drugs work and try to help the patient to prevent this hyperglycemia related to a fear of low blood glucose values at night. So how do we manage these factors? Again, education is very, very important. If you don't have the time and the doctor hasn't done it, you can ask for a diabetes nurse educator from the companies that can assist the patient in terms of using insulins correctly, timing the insulins correctly before meals, and maybe your staff as well. So if you have if you have a student pharmacist or a pharmacist assistant that is dispensing insulin, they need to give the patient the correct advice, because you do have a value in society. It's not just a shop where you take something off the shelf, you just collect the money in exchange. You have a responsibility to the patient as well, to teach them how to use the drugs safely and effectively. Try to advise on safer drug options where possible. Although the patient may have to co-pay because they're not on the right medical aid option to use these drugs, it's still a co-pay in the right direction. Instead of paying for fixing up your car or whatever, if you meet up an accident post a hypoglycemic episode. So monitor renal functions regularly, discuss sick day treatment if you can with your patient that comes in that's seeking some treatment for gastroenteritis and vomiting, etc. Because then you could save a life. Discuss the safety and the risks of fasting and protocols that can be used in these situations. Let them talk to their doctors. Right? In terms of practical tips, we need to understand the pharmacokinetics of each of the insulins that you're dispensing or that we are using. You need to know the duration of action. So you need to know whether that insulin should be taken, for example, 10 minutes before meals, or 12 hourly apart, or with the premixed insulins, with the short-acting insulins. You need to take it before meals. It has to be before meals. It can't be post-meal. And this is something you need to emphasize to the patient so that they don't get these sort of episodes. And we need to make sure that the patients also store the insulin correctly when it leaves your pharmacy. So lots of times patients take the insulin pens and they leave it in the cubby of the car, parked outside in the sun. Remember, insulin is a protein. And when you do this, it denatures the protein at higher temperatures. So then it doesn't work. And some patients keep the insulin because load shedding might happen. So they want to keep the insulin in the freezer. Once you've frozen that insulin, first of all, the vial can crack. But secondly, it doesn't work as well after you've frozen it. So you should not be freezing the insulin. So we need to tell patients how to keep the insulin correctly at home, so that they avoid those kind of mistakes. Right? And then try to accommodate for individualized therapy. And why I added this here is because you do have patients who live in hostels where they don't even have a fridge. And despite the fact that there's load shedding, etc., we rather tell the patient to keep the ice packs in the freezer, and should load shedding happen, put the insulin in the ice packs the way they would store it on their way home as you are dispensing it, instead of putting it in the freezer. So those kind of things we can try and teach the patient to do, to make sure that the insulin is still functional and is being used correctly. So in summary, many patients do not achieve HbA1c targets in clinical practice. And there are a number of reasons of this. One of the most important reasons is a fear of hypoglycemia, right? And doctors also fear hypoglycemia. So it's not only the patient. So if the patient's taking the same dose over and over again and there's no change, then you need to say, go back to your doctor, check your HbA1c, because something's not right here. Right? Hypoglycemia can compromise glycemic control and result in long-term complications. It also has a negative consequence for adherence and can result in higher healthcare costs because the patient is admitted to hospital multiple times for hypoglycemic treatment, when they could just as well have eaten something if they had been given the right advice, or used a glucagon injection. So I'm not sure how many glucagon pens you dispense at your pharmacy, but maybe ask the diabetic patient, are you aware that there is something that can help you with hypoglycemia? Right? So the greatest risk for hypoglycemia is around the time of starting basal insulin. And this is in a type 2 diabetic specifically. So hypoglycemia early after initiation is a strong risk factor for subsequent hypoglycemic episodes, and we should be aware of this. Hypoglycemia early after initiation can result in the patient discontinue the therapy completely. And you would know that because you know the patient's not coming back for their repeat prescription. Thank you for your attention.
Dr. Roshi, thank you very much for a very informative talk. You certainly demonstrated the value of talking to our patients and making sure that they're not having hypos. I mean, when they have a hypo, it can be life-threatening. Just something that's quite interesting, and Ahmed can, he's our COO of ICPA, can speak to this as well, is that we are quite pleased to see that some of the medical scheme funders, and in particular Discovery Health, are looking at putting in place measures to educate patients better. So, you know, you'll probably see your patients maybe twice a year, maybe 3 times a year, if you give them 6 repeats on a prescription. But of course, they come in every month to the pharmacy, and in between, as you were saying, for their sick days when they come into self-care for minor ailments. And Discovery Health is putting in place a benefit now that the nurses in our pharmacies that have been trained as diabetic nurse educators, they are allowing 2 sessions for every diabetic patient every year. On top of that, they are allowing doctors to actually script HbA1cs, lipid panels, and what have you, which can be done at pharmacy level. Every year we run a diabetic campaign, and we have noted, you know, our aim is to screen patients to pick up those that don't realize they're diabetic. But very often we get the diabetic patients coming in and we do their blood sugars, and exactly what you're saying, they are not controlled in the least. And so we've got two projects going. One is treat to target, which is basically what you were saying there, where we try and encourage patients to do a number of different interventions to get their blood sugars correct. And what we're trying to also do is we see so many diabetics that have never had an HbA1c, and is to encourage them to go and have an HbA1c at least once, twice, preferably 3 times a year, so that they do know what their blood sugars are doing. So, Doc, at this stage, I am going to open it to the floor for any questions. And I see there have been a couple of questions in the chat.
The chat box.
Yeah, let me just bring this up. So yes, so there was a question around the fact that insulins can be stored at room temperature. I think that's generally the pen that's in use, isn't it?
No, that is true. So I am looking at the chat at the moment.
Okay.
So so it depends what your room temperature is, right? So that's the issue. So when we talk about room temperature, unfortunately, they're talking of a room temperature of 24 degrees. And the last couple of weeks, I think just towards the end of September, we had room temperatures of like 33, 34, you know. So that's why sometimes you need to find a cooler place, and it depends on where you're living. In terms of room temperature. So yes, the pen that's in use can be stored out of the fridge in a temperature stable area, and preferably at around 24 degrees Celsius. If it's much hotter than that in your house or the space where you're at, or if you're traveling or whatever, preferably just keep it in those ice packs, the gel packs. That's a better way to store it if it's getting very, very hot. Besides that, the insulin pen, if you're having a pen device that has the disposable pens, the material that they use, the plastic that they use to make that, and I was very surprised to hear that, is the same sort of material that they use for aeronautics, because it is temperature stable for up to 30 days, as long as the cap is kept on. So yes, so you can keep the pen out of the fridge as long as you're keeping it at a room temperature of around 24 degrees. So that's something that you need to keep in mind. I see there's another question there which says, which treatments are safest for renal failure patients? Now, when it comes to renal failure, we stratify patients. So we look at the patient's GFR. So most drugs, and if you look in the package insert, have a value at which you need to either stop the drug or reduce the dosage. Like, for example, if you're looking at metformin, if the patient has renal failure and the GFR drops below 30, it's preferable to stop the metformin. Reason being is that certain drugs are actually excreted via the kidney. And if the drugs are not able to be passed out, the drug will have a longer duration of action, resulting in multiple hypoglycemic episodes. So you need to make sure that the patient knows what their GFR is, right? So if you're not certain, I don't know if you do the GFR, but you can actually send the patient back to the doctor to do a proper test, because that's what they need to do, right? So they need to check what their GFR is. DPP-4 inhibitors are relatively safe when it comes to renal failure, but there is a GFR cutoff point. When it comes to drugs like sulfonylureas, etc., they can cause hypoglycemic episodes. Now, why patients with renal failure develop hypoglycemia is because one of the functions of the kidney is to produce 30% of the body's glucose via gluconeogenesis. And once the kidney fails, this source of glucose is also lost. So the patients then also get hypoglycemic events simply because of the kidney failure, right? So what we need to do is we need to make sure that we know what the GFR value is before we say that you can and you cannot use this. Certain patients use insulin because insulin is probably one of the safest drugs. However, if the patients are getting hypoglycemic episodes, you then have to reduce the dose and change to different therapies. So in terms of safety, it depends on the patient's GFR. SGLT2 inhibitors specifically, in South Africa, it's registered only for patients who have a GFR above 40. So when it's under that, we don't use it simply because the drug then doesn't work. The way the SGLT2 inhibitors work is they block the reabsorption of glucose at the level of the kidney, and the glucose is passed out together with water via the glomerular filtration, right? However, if the kidney is not working well, then you're just using the SGLT2 for placebo effect. It does nothing because you're not having adequate filtration anyway. So then the drug is not going to work. I don't think it does any harm otherwise. So yeah.
Thanks.
Now let me see. I see. I'm just going to look at. I missed one comment, which was kind of long. It was we as pharmacists did a CDE course. Can we not get pharmacists accredited? I'm not sure about that one. So that one you'll have to answer. And yes, I do believe that pharmacists actually play a big role in improving patients' compliance and getting them to understand the drug. And pharmacists sometimes know better than some of the general practitioners in terms of which drugs to use when and when to stop. And it's best then to flag that, because I find sometimes I've written a script, say for antibiotics or something like that, and the pharmacist says, but did you know this patient is allergic to penicillin? And I said, well, the patient didn't tell me, but then I was a little bit busy and I didn't ask. And I really appreciate those phone calls, including one patient who was using his basal insulin 3 times a day and bolus insulin once. And he told the pharmacist, that's what the doctor said. Just confused the pins. So the pharmacist was so sharp, actually picked up that this is what the patient is doing, and phoned me and said, look, you need to tell this patient that they're doing it incorrectly, because they didn't want to take it from the pharmacist. And the pharmacist was just spot on with that. Saved the patient's life, I think, right? So is it safe for diabetic patients to use meds for weight loss? Weight loss is actually recommended in a diabetic patient, but safe weight loss. When they're doing appetite suppressants, or if they're doing any sort of drug or even exercise that results in weight loss, the insulin doses need to be adjusted, because we could calculate insulin doses based on the patient's body weight. And as patients lose weight, or if they're eating differently, their insulin doses need to come down, right? So weight loss medications, fine, but the patient needs to know that they cannot for example, use insulin and just not eat, because then they will get hypoglycemic episodes. So it depends on the drug that they're using. If they're using the drugs like drugs that cause palpitations and increase metabolism, etc., be careful, because that patient may have additional hypertension or have had a stroke or something like that, and now they want to use these drugs, and you can result in the patient dying if you dispense any of these other drugs that are available that can cause harm to the patient's heart. So you need to be careful of that. Does symptomatic hypoglycemia put the patient at risk of cardiac arrest? No. Only true hypoglycemia does. Symptomatic hypoglycemia is just the patient experiencing an hypoglycemic episode because of a deficit in blood glucose values compared to what it was. So it doesn't cause an issue. But the patient doesn't know whether it's symptomatic or true, so they have to test their blood glucose values before deciding to act on it or etc. So the patient needs to check, right? Then it's nice that the group is so interactive. I missed something now. What is a few core management tips for the sick? So in terms of vomiting and diarrhea for these patients, if it's very, very severe, it is preferable for the patient to actually go in for a glucose drip. Why? Because in elderly patients, if you cause severe dehydration and the patient has taken a sulfonylurea or insulin, the only way to correct that in the long term, especially if you're using now an MR formulation, that drug is going to work over 24 hours. So you're going to have to eat, you're going to have to be eating on a continuous basis to keep your glucose value up. So in those patients, it's preferable for them to go to a hospital and start to get some sort of therapy. If the diarrhea and vomiting is minor, or if they know it's food poisoning or something like that, in the meantime, they can sip on fruit juice to keep their glucose values up, especially if they've already taken therapy to lower their blood glucose. So that is probably the best management for a patient who is sick. Of course, the best option is to stop the vomiting and diarrhea. So we can give them treatment to prevent that. Like the Maxolons and the loparamides, etc. that we have, that should work very well for the patient if they can keep it in. So now docs are now prescribing Trulicity for insulin resistance. Now, insulin resistance can be caused by weight gain, right? So Trulicity does help a little bit in weight loss. So then it can help a little bit with insulin sensitivity. The other thing that's nice about the Trulicity and the other long-acting GLP-1 receptor agonists, they give you very good postprandial glucose cover, especially in a type 2 diabetic patient, that can help to lower the HbA1c in total and thereby also reduce insulin resistance. In terms of weight loss, yes, a lot of diabetic and non-diabetic patients want to use the drugs for weight loss. In terms of Trulicity, the weight loss that you get with Trulicity is on average 2 to 3 kilos. Whereas with the other SGLT2 inhibitor that you have available, specifically the semaglutide, you're getting a 4 to 5 kilo weight loss on the 0.5 milligram. So Trulicity, there's only one dose available in South Africa. That's a 1.5 milligram dose. And so you're getting about 2 to 3 kilos. Though I have had diabetic patients who've lost a lot more weight, maybe because they have a bigger incretin hormone deficiency, so they actually respond better to these GLP-1 receptor agonists. Incidentally, at the EASD this year, they did mention that they would like to register obesity as a chronic condition. And because of these drugs that are available, specifically looking at the semaglutide, which is Ozempic, which is very potent in terms of weight loss, and it does alter the patient's metabolic profile in the long term, they want to register it specifically for the use of weight. And because there's a big problem in the US and the UK in terms of obesity, and the drugs then are going to be registered for obesity. And hopefully it's going to come to South Africa too, where we can assist patients with weight loss in a safe way, And I think this is probably the safest and the most effective way we have available at the moment. Obviously, only secondary to diet and exercise. However, these patients who have morbid obesity, they have had some trials looking at GLP-1 versus bariatric surgery, and they're giving bariatric surgery a run for their money. So watch out, because there's new drugs that are going to be launched that can give you very, very effective weight loss without putting yourself at risk of surgical complications, etc. If you want to better the use of pharmacokinetic knowledge of the pharmacists, yes, you do need access to their lab records. And I agree with that 100%, because you can pick up whether the patient's therapy is good or not, because I mean, they come to you on a monthly basis to collect their treatment. And I 100% do agree that if you had access to their lab records, your value would, your contact with the patient would be of a better value. So I definitely do agree with that.
Interesting. Sorry, Doc. Sorry to interject there, but that is also something we're looking at Discovery Health with, where they are looking more at this multidisciplinary approach, and
Yes.
are looking in 2023 to give us access via the health ID, so the iPads and what have you, so that with patient consent we can actually see these lab results. So I think that is a step in the right direction.
But I think in terms of the doctors, and I don't know, you obviously need to get the patient's permission to do this, because now of the POPI Act, etc. But if the patient agrees, and if the pharmacist would like to know what the patient's HbA1c is, maybe just request to the doctor, have you done the HbA1c? What's the value? And I could just write it on the script, at the back of the script or something like that, you know, or tell the patient, you should tell your pharmacist, this is what your HbA1c is. So at least you have an idea of what's going on and why the doctor's adding this and changing this, and you know, that sort of thing. Because you just see the script, you don't see what was behind all of this. You know, why did the doctor change? Why are we using this? The medical aids do have that information, because when we want to put drugs onto chronic, we have to motivate to the medical aid why we want to use this, that, or the other. And you guys are not privy to that information, you know, and the patient sometimes doesn't understand what's going on. So I do agree that you need to be kept in the loop, because you're very integral in this entire process, because compliance is a big issue. Yeah, and if HbA1c kits are available in pharmacies soon, that's brilliant. We do point of care testing at our diabetes care center. So when the patient comes in, well, at least every 6 months or every 3 months, depending on the medical aids and where the patient is in terms of level of control, we do point of care HbA1c. Why? Because while the patient is there, I know what the HbA1c is today, and I can adjust therapy today. Instead of sending them off for a blood test and then the secretary files it a week later, but then the patient's gone on holiday, you couldn't get a hold of them or whatever, and you don't exactly you don't make the changes, you know, when you're supposed to, and then you've just kind of lost the you know, it's what you've lost the plot kind of thing, because you're not doing it when you're supposed to. So I think if the pharmacist can do HbA1c tests and the kits are available, it's, I think, brilliant, because the doctors are not doing HbA1cs. Right? Okay, so we have a question here. How best to manage Muslim patients during the month of fasting, especially those on insulin? Okay, so in patients who have an HbA1c above 9% and who have had, so there is something called the a DIA Ramadan study that was done, DIA Ramadan study. And there are also websites where patients can go to, or you could even download, print out, and keep it in your pharmacy. But there are certain patients, depending on a risk stratification system, that are allowed to fast and those that are not allowed to fast, right? So those who are not allowed to fast are those patients who are on a basal bolus regime, who have had 1 to 2 episodes of hypoglycemia per month, and those patients who have metabolic decompensation, like those patients who have complications, cardiac disease, patients on dialysis, etc. They are not allowed to fast according to that program, right? Apart from that, there is the religious aspect. And I mean, and I do know from the imams in our area, if the patient is putting themselves at risk, it is not recommended that they fast, right? So even pregnant women should not be fasting, especially diabetic pregnant women. And because of course you're putting your life in danger, and that is not what God wants, in which case you would have to do something else in terms of charitable acts or fasting some other time in order to catch up, right? However, that's in terms of pregnant patients or patients who are sick on that day. The safest drug to use during fasting, if you're not on insulin, is a GLP-1 receptor agonist, and specifically the once weekly ones. Why? Because they only stimulate insulin secretion when you eat, okay? And you don't get hypoglycemic episodes. DPP-4s, metformin, and GLP-1 receptor agonists are the safest things to use when you are fasting. But it's best to risk stratify the patient according to the calculation that you can do on that website. So you can't just Google hypoglycemia, diabetic risk stratification during Ramadan, and you'll get something that comes up. And it's a very simple thing. It's a one-page thing where you get a score. So you say, if you're diabetic for more than 10 years, then you get a point of you like 4 points. If you're diabetic less than 10 years, it's 1 point. If you're on a sulfonylurea, you may get 2 points. If you're on insulin, you get 4 points. And the higher the number, the higher you are at risk of hypoglycemia during the fasting month, right? In South Africa, fortunately, our fasting lasts, say, about 8 hours. But in other countries, like in the UK, where it's their summer months, in June, the sun rises at about 3 a.m. and it sets at 10. And they're having greater than 15 to 16 hours of fasting. Those patients are at greater risk of hypoglycemia. So we also need to look at the number of hours that the patients are fasting, especially since they're not even taking in any water. So it's not just food, it's also no water, putting the patient at risk of dehydration, a stroke, everything else that can come besides hypoglycemia. So there are multiple studies that were done, and the safest ones, DPP-4s, metformin, and GLP-1 receptor agonists.
Doctor, Doctor, something we've been looking at as well, and it's something that we've had training on, is promoting patients changing their needles more often. So there's been a push to get medical schemes to pay for more needles. There was a time where they would pay for 5 or 10 needles in a month. And then also moving the injection site so that they don't end up with these lipomas. Yes.
Yes.
What is your view on that, on single needle use and migrating the injection site? Oh, looks like we lost the doctor.
Yes, it seems so.
Let's see if she comes back.
Yeah.
And if there are any other questions, please just pop up your hand or put a question in the chat. Maybe she's got load shedding.
Possibly. Let's give it a few more minutes just to check if she can log in back, so that we can say a proper.
Hi everyone. This is Siana from Serbia.
Hi, Siana.
Yes, Dr. Joshi just informed me that she's got load shedding.
Okay.
Oh.
Yes, yeah.
Okay.
So you were quite right to have picked that up. Sorry about that.
All right. Well, Sianda, I think it's been a very useful evening. You can see from the interactive question time that we've had after the talk, Dr. Joshi was absolutely wonderful. So thank you very much to Servia for getting that speaker for us and for being our partner. To our ICPA members, remember, we are going into our diabetes campaign. The 14th of November is World Diabetes Day. We're asking our pharmacists to wear blue. I know our blood is green, but we're going to wear blue on the 14th of November. There will also be media releases. There'll be posters coming out. Lots of pharmacies will be doing free testing. I know there were 25 pharmacies that applied to ICPA to get free strips. Those are going to be distributed soon. There is also the ICPA Health Center, where you can do risk assessments. So that's determining the risk of a person developing diabetes over the next 10 years. And then, of course, there is our Treat to Target campaign, which is exactly as I said, looking at testing, screening patients, seeing if they are getting to their blood glucose levels, promoting HbA1cs, and so forth. So to Servier, thank you very much. To all the members for attending, thank you. And Gabo, I'm going to ask you just to close off the evening, please.
Thank you very much, Jackie. I think you have done a good honors on that one. Indeed, in the absence of the good doctor, a big thank you to her for the work that she has done tonight. Excellent presentations and practical usable information. We really learned a lot. And I believe that we will soon look to hear from her again. I felt a bit nostalgic on the pharmacology there. It was a very good feeling. Thank you so much. And thanks again to the sponsor, Sevia Nadesandile. Thank you, Siabonga Baba. And thanks again to the attendees, our colleagues, the members, for your participation and your enthusiasm to the presentation of the good doctor. We really appreciate that. Remember to log in those CPDs at the SAPC website because this was indeed a CPD event. Let me, at this point, colleagues, bid you good night till we meet again. The meeting is duly adjourned. Thank you so much. Appreciate all of you. Bye-bye.
Thank you, everybody. Keep safe, sleep tight.
Thank you very much, everyone. Good night.
Thanks.